Welcome to another deep dive. Today we are tailoring this specifically for residents preparing for board exams, specifically like the FRCS and plastic surgery.
Yeah, this is a crucial topic for anyone facing those clinical cases.
Absolutely. But really quickly before we jump in, you need to head to medsynclimited.com. You can get the FRCS plastic surgery ANKI deck there, which has over 7,000 questions. They are all arranged by topic to turn your revision into active recall, and it's built directly on the plastic surgery curriculum.
Right. I mean, it really is the go-to companion exam question guide.
It really is. So thank you for being a member, and be sure to check out the full library of premium clinical cases and Journal Club episodes. Okay, let's get straight into it. No wasting time. Today's mission is unpacking Lefort fractures.
Right. A huge topic for the boards.
Exactly. I mean, usually when we talk about a medical diagnosis, there's this expectation of precision. It feels like engineering. You break your arm, the x-ray shows a clean line, and you just fix it.
Yeah, it's very binary in those cases. The bone is broken or it's not.
But with severe facial trauma, that straightforward model it completely falls apart. You look at a smashed midface on a CT scan, and you're looking at a collapsed architectural landscape. So how do we even get the framework for understanding this?
Well, to really understand how we reconstruct the human face today, we have to look back to 1901. And it's actually pretty brutal. A French military surgeon named René Lefort figured this out, but not with computer modeling.
Right. They didn't have high-res imaging back then?
Exactly. He actually used 35 intact cadaver heads. As a military surgeon, he deliberately ignored gunshot wounds. He called them veritable explosions in the face.
Wow. Veritable explosions.
Yeah, because bullets destroy the bones so chaotically you can't find any underlying patterns. So he needed raw, blunt force. He and his aides used wooden clubs, heavy metal rods, and even put the skulls into industrial vices.
Wait, they're crushing them in vices?
Yeah, and they even hurled the heads directly against the hard edges of marble dissection tables to simulate falling from a height.
That's just staggering methodology. So he basically smashes these cadavers, and then what?
Then he boiled the skulls in massive vats to dissolve all the soft tissue. He wanted to strip away the skin and muscle and just look at the naked bone.
Okay, so what did he actually find when he looked at the boiled skulls?
He discovered that the face doesn't just shatter at random. It doesn't spiderweb like glass. The fractures actually occur consistently along these lines of least resistance, which he called the linea minoris resistentiae.
Right, the natural crumple zones, basically.
Exactly. I mean, the human skull is this dense vault protecting the brain, but it sits on top of this highly aerated, lightweight scaffold, which is the midface.
Because of the sinuses and everything.
Right. You have thick vertical pillars to handle chewing, but between those pillars are these fragile, paper-thin sheets of bone around the sinuses and the eye sockets.
See, I often think about automotive engineers designing car chassis to fail in specific areas. But a car crash is so chaotic. How does a face break in predictable patterns under those chaotic real-world conditions?
What's fascinating here is that the chaos of the impact just can't override the internal architecture of the skull. The energy travels through the dense pillars until they fail, and then it immediately shears through the thin sinus walls.
Ah, so the path of least resistance is always the same because human anatomy is mostly uniform.
Right, exactly. And the defining feature Lefort found was that all of these high-energy fractures result in the separation of the maxilla, the upper jaw, from the base of the skull.
And that universally involves the pterygoid plates, right?
Yes, always. If the pterygoid plates of the sphenoid bone are intact, the upper jaw hasn't truly separated from the skull base.
So for the residents listening, no broken pterygoid plates means it is not a true Lefort fracture.
Spot on. That is a massive diagnostic criteria for the exams.
Okay, so let's translate this 1901 boiled skull research into the modern classifications of midfacial collapse. We have 3 foundational types. Can you walk us through them?
Yeah, absolutely. The system organizes the fractures based on the volume of the facial skeleton that detaches from the cranial vault. The higher the energy, the higher up the face the fracture goes.
Okay, so let's visualize this like a collapsing multi-story house. The ground floor gives out first, right? Type I.
Right. Type I is a horizontal shear. It's caused by a downward force below the nose, right above the teeth. It literally separates the hard palate and the upper teeth from the rest of the face.
So clinically, how does that look when they roll into the ED?
Usually you'll see a really swollen upper lip, but the key is the floating palate. The structural floorboards of the nasal cavity have just given out completely.
Got it. Moving up to type 2, the energy is higher up now.
Yeah, type 2 is pyramidal. The force hits the lower or central midface. The fracture travels up through the maxilla, across the nasal bridge, through the lacrimal bones, and the inferior orbital rims.
Right, so using our house analogy, this is like the entire front porch and the central bay window collapsing as one unit.
Exactly. When you examine a type 2, the nasal bridge and the upper jaw move together as a single combined segment.
Which brings us to the apex, the type 3 fracture.
Yeah, type 3 requires massive energy, usually a direct hit to the nasal bridge. This fracture runs completely transverse, parallel to the base of the skull.
So it's taking out the zygomatic arches too.
Right. It shears the nasal bridge, goes through both orbits, snaps the cheekbones, and of course fractures those deep pterygoid plates. We call this craniofacial dissociation.
Meaning the entire midfacial skeleton just completely detaches from the cranial vault.
Yes. Gravity and muscle tension pull the whole mass of the face down and backward, which causes what we call a dish face deformity.
A dish face deformity. Wow. But I have to push back a bit here. These classifications sound perfectly symmetrical, but a steering wheel to the face doesn't hit perfectly dead center.
No, you're totally right. In the real world, these rarely happen perfectly symmetrically. You can easily have a type 2 on the left side of the face and a type 3 on the right side simultaneously.
So it's just a highly complex asymmetrical puzzle.
Exactly. High energy, blunt force trauma is incredibly chaotic.
Okay, so practically speaking, for the boards, how do you diagnose this invisible damage in a trauma bay when the face is massively swollen and bleeding before you even get to a CT scanner?
It requires a really hands-on physical exam. First, you secure the airway. Then, you literally grasp the premaxilla, the front of the upper jaw, and you rock it back and forth to see what moves.
So if you wiggle the teeth and just the palate moves, that's type 1.
Right. If the nasal bridge moves with the teeth, it's type 2. And if the whole front of the face shifts independently of the skull, that's your type 3.
What about checking their bite?
Crucial step. You have to check their occlusion. A classic sign is an anterior open bite.
Meaning the back molars are touching, but the front teeth are propped open.
Yeah, exactly. And the mechanism there is purely muscular. Since the pterygoid plates are snapped, the pterygoid muscles lose their bony anchor.
Oh, I see. So the muscles just contract.
Yeah, they function like a snapped rubber band. They uncontrollably pull the entire broken upper jaw backward and downward, which wedges the back teeth together and levers the front of the mouth open.
That is such a high-yield concept for revision. Okay, but here's where it gets really terrifying. When the upper face shatters in a type 2 or 3, you might be dealing with a skull base injury, right?
Yes, and that brings us to the halo sign.
Right, so if you see clear fluid diffusing away from a drop of blood on a paper towel,
You are likely looking at cerebrospinal fluid, or CSF. It means the bone separating the nose from the brain is fractured, and brain fluid is actively leaking out.
that completely changes the triage game, doesn't it? How do you secure an airway if the nasal cavity is basically open to the brain?
It creates a strict contraindication for nasotracheal intubation. You absolutely cannot push a breathing tube blindly through the nose because you could easily push it straight through the fractured cribriform plate directly into the brain cavity.
Just a completely catastrophic outcome.
Yeah.
So obviously getting a fine-cut CT scan is the gold standard here.
Yes, slices equal to or less than 3 millimeters are essential to map the fragments.
But you don't rush them to the OR immediately to fix the bones, do you?
No, you generally delay surgery a few days to let the massive soft tissue swelling subside, but you only have about a 1-week window.
Because if you wait longer, the bone fragments start healing in those collapsed, displaced positions.
Exactly, and then you have to deliberately re-break the face to fix it.
Okay, so you're in the OR within that week. The goal is to rebuild the scaffolding, the facial buttresses.
Right, the vertical buttresses dictate facial height, and the horizontal buttresses dictate width. But the very first step actually starts with the teeth.
Which is counterintuitive. You'd think you'd start with the cheekbones.
If we connect this to the bigger picture, trauma surgery is all about securing mobile segments to stable ones. You use maxillomandibular fixation, or MMF.
So wiring the jaws together over Eric arch bars.
Yes, you lock the upper and lower teeth into their original bite. This uses the intact lower jaw as a stable foundation to anchor the floating upper jaw.
It's like locking the foundation of the house in place before you try to rebuild the walls.
Perfect analogy. Once the foundation is set, you work from the outside in.
Let's talk about the specific surgical exposures for the exams. How do you get to the bones?
For a type I, you use a gingivolabial sulcus incision. You cut horizontally high up inside the upper lip.
So no external scars. What about type 2?
For type 2, you need a mid-facial degloving approach. You combine the lip incisions with incisions inside the nostrils, and you literally peel the soft tissue of the face up to the eyes.
Wow, just peeling it up like a mask. And for type 3?
That requires a coronal approach. You cut from ear to ear across the top of the scalp and peel the forehead and upper face downward.
Okay, once exposed, you're plating these bones. You're using tiny titanium hardware, right?
Very precise hardware. 2 millimeter plates for the load-bearing buttresses and microplates down to 1.3 millimeters near the eyes.
But there's a huge physiological risk when you're drilling into bone, isn't there?
Yes, thermal necrosis. Bone is living tissue full of osteocytes. If the friction from the drill heats the bone above 40 degrees Celsius, about 104 degrees Fahrenheit, those bone cells will die.
And if they die, the titanium screws will just loosen and the reconstruction fails.
Exactly. So the assistant must constantly irrigate the drill site with chilled saline to manage that temperature millimeter by millimeter.
Okay, so the bones are plated, the foundation is locked, but fixing the bones is just the structural work. We have to talk about the soft tissue closure, right?
Right, because if you just stitch it up, gravity takes over. The soft tissue has been stripped from the bone, so it will droop, causing severe facial ptosis.
So you have to meticulously suspend the soft tissue back to the periosteum.
Yes, and there are specific techniques you need to know. For instance, moving the maxilla naturally makes the base of the nose want to splay wide open, so surgeons use an alar cinching technique.
That's a deep suture to basically pull the nostrils back together and restore the nasal width, right?
Exactly. And manipulating the upper jaw also stretches out the upper lip, making it really thin. To prevent that, you do a V to Y advancement closure inside the mouth.
You cut a V shape and suture it closed as a Y shape to push bulk tissue forward.
Right, it preserves the natural projection of the lip.
So we've talked about how devastating these injuries are and the sheer artistry of fixing them. But what does this all mean in terms of prevention? I mean, motor vehicle accidents are the leading cause, right?
Yeah, MVAs account for about 50% of all LeSort fractures. The historical data here is really striking. In 1983, the UK introduced mandatory seatbelt laws.
And what was the impact on facial trauma?
Within just 2 years, the incidence of maxillofacial fractures dropped by 2/3.
That is massive. But here's what I want to know. Modern cars have airbags, which are literally designed to cushion your face. Why does the data show that an airbag without a seatbelt fails to prevent these fractures?
It comes down to the physics of the deployment. An airbag expects you to be anchored by a seatbelt. If you're unbelted, your body is still traveling at full vehicle velocity toward the steering column,
Right.
and at that exact moment, the airbag detonates outward at over 200 miles per hour.
Oh, wow. So it's not a cushion at all in that scenario.
No, it becomes a rapidly expanding solid object, striking an unanchored, accelerating mass. So without a seatbelt, the airbag deployment itself can actually cause a complex craniofacial dissociation.
The airbag causes the fracture.
Yeah, the safety system requires the body to be properly anchored to the chassis to work.
Well, we've covered a huge amount of ground today for your FRCS revision, from Renee Laford boiling skulls to map the lines of least resistance to identifying the floating palate of a type I versus the dish-face deformity of a type 3.
And don't forget the vital importance of the physical exam. Checking for that anterior open bite, looking for the halo sign, and knowing why nasotracheal intubation is an absolute contraindication.
Exactly. And then understanding the surgical sequence. Anchoring the teeth with MMF first, working outside in on the buttresses, and managing the soft tissue with V to Y advancements and alar cinching. It really reframes how you look at the human anatomy.
It absolutely does.
So we want to leave you with a final provocative thought today based on that airbag data.
Yeah, I mean, if airbags deploying without seatbelts can completely fail to prevent or even cause complex mid-facial fractures, it really raises a critical question about the illusion of safety. What other modern safety technologies are we relying on daily that might actually be creating a false sense of security simply because we aren't using their foundational anchors?
It's definitely something to chew on carefully. We really hope this revision session was helpful. Please drop down and leave a comment or a question about today's topic. And remember to head over to medsynclimited.com for that ANKI deck. We will catch you on the next deep dive.